Deepak Puri. He is Director CTVS in Max Super Speciality Hospital, Mohali, India. And he will be presenting on the topic Integrated Approach to Comprehensive Management of Cardiovascular and Thoracic Diseases Improves Outcome During COVID Pandemic.
My talk today, I would like to just share a few issues that we have been facing for the last few years, especially in India. And one of the issue is the COVID pandemic, which has affected the entire world. And apart from that, in India especially, we face a few issues which we would like to share that has become a threat to the cardiovascular surgery practices for most of the surgeons, and now less people they are coming forward to take this specialty. So one is that the Indian patients, they are getting affected at a much younger age, but they present when the disease has already progressed a lot. So we have to face more operating difficulties. Plus there are certain myths promoting which are delaying the treatment to be started, because patients they keep on trying their own, like Dr. Vivek mentioned about Ayurvedic medicine also, and there is non-evidence based promotion of unconventional therapies which may actually delay the treatment, and the patient may come to us with some complications. And there is also injudicious use of some complicated technologies which people promote, and people they go on net and they Google and they come and they demand that we should do that procedure for them. At the same time, the morale of the surgeons is also not in a very high spirit, and this is because there is lack of infrastructure, there is lack of skilled professionals, and there is cost cutting, and at the same time the doctor-patient relationship is also deteriorating day by day. So keeping all these things in view, we started a global group called Cardiomersion in 2011. The basic purpose was that we wanted to promote the integrated approach in which all the specialties which are dealing with a patient who requires treatment for the heart, they come together, and at the same time we deliver comprehensive management of cardiovascular diseases, which begins from the primordial prevention in the childhood, and then primary prevention, early diagnosis, medical management, and later on if some complications develop, then the interventions. And after that we also give very importance to the rehabilitation part, and then the secondary prevention. So the problem is that most of the people they come to us only at the time of interventions, and by that time already the disease has progressed a lot. So if the patient comes to us with badly diseased vessels, and like we have to do very complicated procedures, as Dr. Vivek has already described one of them. But if we adopt the comprehensive approach, we can delay the progression of the disease, and the patient might come to us when they are in a better condition, and the long-term outcome may be better. So this comprehensive management was tested to the fullest during the COVID pandemic, when the patient used to arrive to us late, and they also presented with comorbidities, and also the risk of surgery was much higher compared to the pre-COVID area. And also we have seen that by adopting this integrated approach, we could achieve better results, which I will show in my next few slides. So whenever the patient needs an intervention, like the armed forces, they have the army, they have the air force, and they have the navy. Similarly, surgeons also, now we have the RP, which is the open surgical techniques, and then we have the endoscopic surgical techniques, which are like the air force, and we also have the navy, like the percutaneous techniques, where we go through the blood stream and then we do the procedure. So once the COVID came, after that the complication related to the lungs as well as the heart, they became more prominent, and patient used to have they used to come with us with heart failure, they used to come with us with badly diseased lungs, and we categorize the patients into various categories depending on how they presented to us. So these categories included those patients who developed complications directly related to COVID, like pneumothorax or disturbed lungs, ARDS, and also developed cardiac complications like acute MI and heart failure. And there were other group of patients who had worsening of their underlying disease because they could not come in time and they were stopped because of the lockdowns. And there was a third category of patients in which the disease progressed to such an extent that they deteriorated and they were in a much worse condition and required major high-risk surgeries when they came. And there was another category of patients, or those patients who had already undergone surgical procedures, but they developed COVID, and we did not have enough beds to admit them into the hospital, and we had to manage them with video consultations, and we have to manage them at their home. So these are the type of coronary arteries. Usually the patients who are diabetic, they have calcified, badly diseased arteries. Sometimes two arteries are totally cut off and the third artery is also badly diseased, and patient has got very small collaterals and badly calcified, diffusely diseased vessels. And we have been doing all the procedures on beating heart for coronary revascularization and with the use of octopus stabilizer and intracoronary shunts. Most of the patients, they come to us loaded with anticoagulation and antiplatelet drugs. And whenever the patient is loaded with antiplatelet drug, we have to screen some donor for platelet to be given by apheresis. We usually don't give the platelet donation unless it is really needed. We just screen and just keep the attendant available at the time of surgery. IFBP was used whenever required. Only 3 of our patients, they required intra-aortic balloon pump, and troponin I was performed on admission, and we used the level of troponin as a guide to when to time the surgery, because I had already published a paper which I presented in Japan several years, almost 15 years ago, in which we found that whenever the troponin levels are too high, if we take the patient for surgery, by that time already damage is done. So we have quite a large number of complications like arrhythmias and low output in the post-operative period. And if once the window period of 8 to 12 hours is crossed and already if we feel that the infarct has already occurred, then it is better to wait for 48 to 72 hours when the troponin levels start declining, and then we operate the patient to get a better result. So the patients, only 3 patients out of 338 who had coronary bypass, they required intra-aortic balloon pump, and patient required low inotropic support in the post-operative period. Only mild support was used in 302 patients, moderate support was used in 30 patients, and high support was used only in 6 patients. And conversion to pump was 2. The indication was ventricular fibrillation and hemodynamic collapse, especially after acute coronary syndrome and cardiogenic shock. And in the post-operative period, usually the patients were extubated in the same day evening, or they were ventilated overnight to be extubated next morning. Only 6 patients required prolonged ventilation beyond 24 hours. So here you can see one of the patients who had a massive MI, and you can see the anterior wall is hardly moving. This patient was in cardiogenic shock, and he was stabilized and then taken up for surgery. And when we operate such a patient, we have to be very careful. Here you can see that the stabilizer is placed a little away from the major infarcted zone, because we have to prevent peroperative rupture of the ventricle, which can occur when you put the octopus stabilizer very near to the infarcted zone, and also the suction is kept at a low, not more than 200. And here you can see we have been able to revascularize the patient, and after the surgery the patient recovered slowly but did very well. And we did hybrid procedures in 3 patients, in which the patient came with acute MI, and in one of the patients the OM was revascularized. And recently we had a patient who was COVID positive when he was being taken for surgery. So we got the culprit vessel, which was the right coronary, was stanted, and later the patient has to undergo the revascularization of the left side for the left main coronary disease, which was not stentable. And then the left ventricular ejection fraction was quite low in most of the patients. 253 patients had an ejection fraction of less than 35 out of 338, and 8 patients had ejection fraction less than 25, and 5 patients had an ejection fraction even less than 20%. And the Euro score ranged from 1.5 to more than 20. So one of the patient who was 84-year-old, and he had renal failure also, and acute MI and low ejection fraction, and the total Euro score came more than 20. So apart from coronary revascularization, we had thoracic cases also. Many of them, they had complications because of COVID. Out of them, most of the patients, there were 81 patients had video assisted thoracic surgery, and here you can see this is segmental resection being done for a patient who had post-COVID mucormycosis. And we had decortication done for 32 patients, and medial channel tumor was excised in 8 patients, all done through video assisted thoracic surgery. We had 2 patients with giant bronchogenic cysts, and segmental resection was done for pulmonary carcinoma in 5 patients. And pulmonary aneurysm was excised in 2 patients, and one of them was post-tubercular. And pulmonary mucormycosis was removed in 2 patients with segmental resection. Here you can see that one of the patients who had post-COVID empyema, and with the pleural thickening and collapse of underlying lung, undergoing VATS decortication. Patients with endoscopic stenting for the aortic aneurysms, we had 3 patients, and we will be showing you the videos of those patients. So the post-operative results were very encouraging, and in all except 5 patients, the average length of stay was 3.2 days post-operative. So most of the patients, they were sent on the 3rd or the 4th post-operative day after Off Pump Coronary Revascularization, and 2.4 days after video assisted thoracic surgery. We had 3 mortalities. One patient had respiratory failure because that patient had acute MI, and 86-year-old female, and had underlying COPD. And there was another patient who had multiple MI, came with severe LVF, and had a very low ejection fraction. That patient went into multi-organ failure, and one patient had a pre-operative ventricular arrhythmia, which was refractory to the TPA insertion, and also refractory to CPR. And that patient was posted for surgery, but just 2 hours before the surgery, the patient collapsed in the ICU and could not be revived. So we found that although patients, they present late and with more comorbidities and complications, integrated approach was beneficial for comprehensive management, as it reduced the further morbidity and mortality despite a higher perioperative risk, and therefore resulted in a much better outcome.